We are live.
A very good evening to one and all. Today we've gathered for another iFocus online session. This is lecture number 413 in the Cataract series. And we have esteemed faculty Dr. Sajjad Fazili from Center for Sight, Srinagar, who will be taking us through management of hypermature cataracts today. We welcome you, sir. I will also have this privilege to introduce our moderator for today's session, Dr. Varun Malhotra. He's a senior consultant, clinical head in cornea, cataract, and refractive services at Center for Sight, Hyderabad. He's also the course director of Eye Opener CME series. He's a mentor par excellence, and he loves teaching all the PG and other DNB students. He's also a research invigilator, multiple publications, and has been conducting various training programs. He's a pillar to iFocus. I welcome you, sir.
Thank you so much, Kanika. Thank you.
We also welcome Professor Dr. Arvind Kumar Maurya, and we would welcome his comments along with our chairperson today. Over to you, sir, for our speakers and chairperson's introduction.
Right. So I welcome Dr. Fazli today. He will be our speaker for today. Dr. Fazli currently heads the Center for Sight branch at Srinagar in Kashmir. And of course, he's done loads and loads of cataract surgeries and also received his gold medal from the IRSI for his pioneering work. And we are proud to have him today to take a lecture on hypermature cataracts. Our chairperson for today is Kallam Shrikant Vaikar. He is an army man and also a fellow alumni from Shankar Nethralaya, Chennai. He's worked as a senior advisor in ophthalmology in armed forces. He was also the professor and head at INHS Ashwini in Bombay. And he has served in armed forces over the last 34 years. And we are very proud to have him today with us. And obviously, very warm welcome to extremely close friend and fellow Hyderabadi Arvind, who heads the Department of Ophthalmology at AIIMS BB Nagar. And we have spent a lot of time together. I've had a lot of interactions and I've learned a lot from him, both professionally and personally. I don't want to, introduce him by saying how many publications he has and medals he has. He's a great human being, and I welcome him today.
Thank you. Thank you, Kanika and Dr. Varun. Thank you so very much.
So over to Dr. Fazli. Sir, we are eager to hear you today.
Thank you very much. My screen is shared?
Yes, sir, it's visible. You'll need to go to the presentation mode. Yes, sir.
Yeah. It's a pleasure to be a part of iFocus. I think it's doing fantastic disseminating knowledge to postgraduates and other ophthalmologists who are willing to learn. Learning process is always a fantastic thing. And I take great pride in being a part of this teaching program. So we're going to talk about hypermature cataracts. So we know no two cataracts can be the same. And there's always an issue when we are confronted with special situations. And hypermature cataracts, we know, become white when degenerating cortex reaches an hyperosmotic state inside the capsule and draws in fluid. And as it draws in fluid, we know that the lens swells up and becomes white. And slowly the lens becomes white, intumescent, and then the anterior capsule and the posterior capsule become dense and the nucleus becomes heavier. And as the cataract is getting more and more mature, there's a tendency for the lens to get swollen up, and with the result that the anterior chamber becomes shallow, and then there are additional difficulties. So one of the major difficulties in management of hypermature cataract is that there's no red reflex. When there's no red reflex, we know we are not able to see things well. There's a difficulty in the visualization of the capsular axis against a white background. Against the red reflex, it's quite comfortable, but when there's no red reflex, there's an issue here. And then because it's stretched, this anterior capsule is stretched, that's why there's a possibility of an extension of the capsular axis upon opening of the capsular bag, and sometimes the most unwanted complication can be an Argentinian flag sign. And also the nucleus within this bag can differ. It can be a milky cortex with a little bit of soft cataract. It can be a freely mobile nucleus that's hard to hold in place and difficult to remove with typical maneuvers such as divide and conquer. And then there can be a difficulty in nucleotomy also. So, when there's a hard behind the white and soft, there's always this difficulty of not having a epinuclear cushion so that we can do a nucleotomy safely. So there's another issue here is that we know that the phacoemulsification surgery is performed in a limited confined space, and adequate space can lessen the damage induced by phacoemulsification in terms of endothelial cell loss. So anterior chamber depth becomes very important. We see through a smaller space, we are having a more difficulty. We're closer to the endothelium. And shallow anterior chamber may not be the only issue. A long corneal tunnel is associated with increased risk of endothelial cell loss due to involuntary uphill work because we have a shallow anterior chamber. The phaco probe has to go in like this. And it will also cause some corneal distortions while working through a long tunnel incision and make visualization compromised. And short tunnels are indicated in such cases to reduce early postoperative endothelial cell loss with the eyes with short anterior chamber depth. You can see this a short one, and then we go in. Now, trypan blue is perhaps most critical to these. We know that since the capsule might not be visible, there have been a lot of struggles regarding how to do a safe capsular access in the hypermatures. But we know when trypan blue came in, and suddenly things became very comfortable because it stains the anterior capsule, and when it stains the anterior capsule, we can visualize it properly, and a proper capsular access is possible. And that capsular access is already difficult, so best is to use higher density viscoelastics and aim for a small access. And also, if everything goes well, then we spiral out. You see, I have started here. I've used a higher density viscoelastic, sodium hyaluronate, and I'm making a small axis here. The aim is that it should not run to the periphery. Once it's going fine, there's no loose cortical matter here. There's no milky cortical matter. All the lens fibers are swollen, but it's not that much that I'll have a problem. I am just spiraling out and making this capsular access come to a size which is adequate enough for a safe capsular access. Now, it's also very important here to know, I'm going ahead with the cystotome, but the use of forceps is also a fantastic tool, and it can be used when we are maneuvering and changing the capsular access size. So you can see here, I'm puncturing in the center. There's a egress of fluid. I'm pressing the posterior wound or posterior lip of the wound, and this allowing this fluid to go away, and it reduces the capsular access, the tension inside the bag. Use of microforceps is excellent. You haven't seen, I'm decompressing. I made a small axis. Now I'm decompressing and then putting viscoelastic again, making a small nick, and then using the microforceps to slowly increase this capsular access size to a size which is adequate. And you can see I'm using it bimanually, going through the other side so that I have an ease in moving this capsular access. It does not matter if you have to change hands a little bit, but ideal size capsular access should be achievable even in the most intumescent and the most difficult of hypermature cataracts. This is another hypermature with the liquefied milky cortex. Here there's constantly going to be some disturbance. You can see I went in, I punctured, and you can see a lot of fluid coming out. The viscoelastic is allowing it to come out because I've depressed the lip of the side port, and you can see it's coming out. You can wash it away because now the stretch on the capsule is gone, or you can use viscoelastic again and try and make this. You can see a lot of fluid coming out, and it's disturbing my progress of the capsular rexus. So I'm putting in viscoelastic again, and then we are going ahead and shaping a small size capsular rexus. I'm using micro forceps here, and you can see with maturity there might be some anterior capsular changes also, some fiberoptic changes also, so the capsular rexus might not progress as easily as we would expect to. Again, a lot of milky cortex coming in, disturbing our view. It's always good to use viscoelastic again and again, and try to regrasp this capsular rexus till it reaches a good size. At this point also, you can see there's some amount of capsular thickening, and I go on and complete this. Now, another thing which I found very, very useful is de-stressing the center. You know, when the capsule is like this, the possibility of falling down from the two sides is much more. But if it's flatter, the possibility of you being able to do a safe rexus is more. I've stained the capsule. Now I am going in with a rod, a blunt rod, and I'm pushing whatever flocculent, swollen cortical fibers are in the center. You can see I'm moving them away from the center so that it flattens the center of this nucleus a little bit. This is easily possible, and when you're using a blunt instrument, surely you're not going to traumatize or hurt the anterior capsule. It has to be blunt, and you move it, and you can see now that I have had a more or less central area where things are rather flattened. And then once that is done, you can see I go in again, and I don't try to make a very big rexus. I still in the same area which I have de-stressed and flattened with that blunt instrument. I make this size bigger. It's moving on nicely. It's always very important that during the surgery you are constantly thinking, and you are trying to make your plans. All plans cannot. Many things have to be planned preoperatively, but the best planning is to be constantly thinking and focusing while you are operating. You can see we have completed a reasonably good size rexus, and all the fibers which were in the center causing a peaking of this lens in the center, they were taken care of. Once that is done, you go ahead and remove whatever free cortex there is, and then you do a nucleotomy and do a cortical cleanup, and then implant a lens. I'm not perhaps very, very happy with the size of this rexus. So at the end of it all, I'm just making a small nick after I've implanted the lens, and I am trying to make this capsular rexus of a bigger size so that it doesn't, because we know that where the rexus is small in these cataracts, there's going to be a capsular phimosis. If we leave too much of anterior, the anterior capsular opening is small. So I've reshaped it after I've implanted the lens, and you can see here that a reasonable size rexus, a good size, something which I'm satisfied with. And repeated injections of intraocular of OVDs is very important to counter the high intralenticular pressure inside. If even if you see that you're aiming for the small rexus, things might still be so intumescent inside. The intralenticular pressure can be so high that actually it might not still go well. Many people would at this go shift to forceps, but you can see the rexus is about to extend on one side. I can see it go away, and then I am injecting some more viscoelastic and controlling it. Even if it is eccentric, I am trying to take it away a little bit. And once you take it away a little bit, and then you bring it back. It's always very important that you progress slowly. Put viscoelastic again and again, and then move on and make it safer for yourself. Air bubbles can be very irritating. You see, I've shifted to forceps because now I would not want further trouble, because if you have a hard surface beneath the capsule, it's easier. So you can see I have now made a slightly oval rexus, and it might not be an adequate size, but I can always go in and reshape it to a better size. And it's very important when I said that we make a small rhexis, you are not very aggressive. See, I'm very casual here. I made a small rhexis. I want to decompress these fibers because these fibers also cause a little difficulty, and I'm not careful here. So this is this step has to be done very, very carefully. Here I already have landed up with a problem, so I am just making a nick in the anterior capsule because now the intralenticular pressure is not much, and then reshaping whatever I can so that I have more or less, except for this one small tear at one place, I have more or less a good anterior capsular surface, and I have a good rhexis. And I will go from this side also and make a small nick here so that the stress on this area is not much. And during the phacoemulsification also, because there is an area of capsular tear, so I have to be very careful and be away, not too much lateral separation when I'm doing the nucleotomy, and not doing too much on this side. At the same time, in cases like this, you're always looking at the capsule, whether the capsule is fluttering or not, because easily this small area from where the capsular axis has gone a little away, we've lost it there, it might proceed to the posterior capsule, and then there is going to be a problem. But we see we've finished this case well, absolutely no issue. So this debulking, another way of handling it is if you use the Simcoe cannula or you use the IA probe, because these swollen lens fibers, even though the central part, if there's no milky cortex, the difficulty might not be over unless you remove these swollen fibers. Once a cut is made, again, we are again resizing it to a good size, and then the capsule, the phacoemulsification becomes easy. So the two steps, continuous curvilinear capsular axis is the safest. That's the way to go. But the Argentinian flag sign, yeah, there is always going to be some cases where there's going to be difficulty. Here I'm using sodium hyaluronate. As soon as I touch and try to extend it, this is what happens. You touch, I'm just trying to lift this flap, and yeah, because of the high intralenticular pressure, the Argentinian flag has happened, and we again reshape this capsular axis, go in one side, and use the micro scissors, because this is not the time where you should be trying to remove this cortex or anything, because this tear can easily extend to the posterior capsule. You can see here I have reshaped and got some semblance of a axis, and then I have to be very careful. Luckily, usually these cataracts, which have such intumescence and which have an Argentinian flag sign like that, they are soft cataracts, and you can see very easily taken care of. And the fluttering capsule is so important. You never come out once you finish, whether it's a phaco probe or anything. I'm putting viscoelastic before I'm coming out, so that there's no fluctuation in the anterior chamber. If there's a fluctuation, that's the time when these tears can move on to the posterior capsule beyond the equator. So you'll see, as soon as I finish the IA, I'm putting in viscoelastic again so that the anterior chamber does not decompress, and then putting the IOL in the bag so that it remains in an area where it's best supported and covered by the capsule. So because we want it to be in the bag, we don't want it to hurt the areas where it is so deficient and weak. And then there's the puncture-axis. I have limited experience with this. This is a video by Dr. Mohan Rajan. You go in with high phaco power and just go in, and two things happen. One is there's a small puncture in the center. Another is that you have already taken out some amount of fluid. You've already taken out some amount of intralenticular pressure out. And then you move on, and you reshape this rhexis to a size which you'll be comfortable with. Obviously, when you are handling this, we know that in white cataracts, perhaps the capsular axis challenge is the most important challenge. And once that challenge is done, we are able to complete these cases nicely. And you can see here that more or less a good capsular access is done. But my personal um, experience with this is limited. And nucleotomy is usually not an issue. It will be either a absolutely soft cataract, or it will be a cataract which is easily taken care of. But sometimes there are going to be hard nucleuses behind. And I told you before also, there's a major difficulty if there's a small Morgagni cataract, there's a liquefied cortex all around, and in the center there's a hard nucleus. The problem with that hard nucleus is that it's going to float around, it's not going to stay, you're not going to get a good grip, and there's not going to be any epinuclear cushion. And that epinuclear cushion is so critical to a safe nucleotomy, especially if you have a hard nucleus. I'm showing you a hypermature cataract because we talked about shallow anterior chambers. Filtering surgery has been done. This is a hypermature cataract with a shallow AC. Again, I told you these tunnels usually become longer because you are trying to save the iris of the patient from getting traumatized. You make very careful incisions. This is very, very important. You can see the level of shallowness of the anterior chamber. I'm finding difficulty in actually trying to avoid the iris while I'm going in. And you can see it doesn't matter if it takes a few attempts, but you have to avoid traumatizing the iris. Once that is done, you go in, you can see I'm going in, and this is slightly longish entry, and I see I've still not been able to go through because this is a very an eye with low intraocular pressure because filtering surgery has been done. Finally, I go in again, and I put some air, and then I put some Trapen blue, and then go in and put some viscoelastic. And I know this type of white hypermature cataract is not going to be easy to remove. The rhexis is not going to be easy. So you always go in and you have a pupil expander. And once you have a pupil expander, you know that you are going to have a good degree of pupillary expansion, and you will be able to do a safe capsular rhexis and a safe nucleotomy. I'm placing the iris hooks, and then you can see that challenge of the capsular rhexis is still there. And we are going ahead and making a rhexis using a capsular rhexis forceps and making it a good size, and then doing a nucleotomy. This is only possible if you have adequate amount of exposure to the lens. And once that is done, you implant a lens. And again, here I might feel that the capsular rhexis size is not good enough. There is a small amount of the capsular rhexis is covering this area. So what I do is make a small nick, and again make it reshape it to a good size. It's also another challenge when the hypermature is traumatic. With traumatic hypermatures, you're never sure what's happening behind. You can do a B scan. You can see, of course, a B scan in all hypermatures is required. But when you have a deep anterior chamber, you're worried that the posterior capsule might have been hurt. And this is a patient like that. I have seen that on the slit lamp that the cataract is hypermature, but it has a deep AC. And I am always mentally ready that there's something wrong here. So you stain, and also with traumatic cataracts, you'll see the capsule is not uniform. It might be fibrotic at some places. It might be a little thick at some places. You can see I'm trying to raise a rhexis here. There's a big difficulty. I'm raising a rhexis here, but I'm not able to make it move as comfortably as I would want to. And as I'm pulling it, you can see here, here I'm causing a lot of pull. So I'll have to leave this here. You have to be looking through the microscope all the time. Obviously, you would want to focus on the capsular rhexis margin, but you're also looking at everything. So I decide not to go from there, and I make a cut on this side and then complete the rexes from this side, because there seemed to be a slightly weakish zonules on this side because they were causing attraction on the lens, and I was pulling it in a slightly uncomfortable way. So I come back from this side and complete this rexis, and lo and behold, when you go in and try to clean this up, this is a very soft cataract. This is how traumatic cataracts can be, and you don't need to go in with a phaco probe. You can go with an IA, because IA is going to be slower. It's going to be more comfortable, and it's not going to be abrupt. And because obviously the bore of the phaco tip and the bore of the IA, this coaxial IA, is not the same. So this proceeds a little more controlled, but I'm very careful that I know the chamber was deep. So I'm staying in a plane where and I can see now that there is a pre-existing rent there. So I have to be very careful that I'm in a plane so that I'm not pulling the vitreous. So it can be very, very difficult here. So in order to reduce the time which you would later on need in a vitrectomy or any other surgical procedure which you would require to remove this cortex, which you would go inside, fall into the vitreous. I'm trying to be very, very, very careful. And another thing is that you should never come out. In these situations, even if you come out, you should put in viscoelastic so that chamber also always remains inflated, and you're not going inside. I can see the rent which was there when I started removing this cortex is still there, and it has not extended. And there's a little bit of cortex here. I'm going in and removing that very carefully. I have to, even if you leave in these cases a little bit of cortex here and there, it's better to bottle that for a more extensive procedure which we might need if you try and remove the wisp. Again, you see, I'm coming out, but at the same time, I'm not coming out before I inflate the anterior chamber. And once I inflate the anterior chamber, the posterior capsule is where it is, that rent is where it is, and I go in and I implant a 3-piece lens. And I place the 3-piece lens in the sulcus, and then you can see there was superiorly some amount of cortex, and that's displaced now. I place the optics inside the capsular axis. So in practical terms, I'm going to cause a capture here. I'm putting in the other optic of this 3-piece IOL in the sulcus, maneuvering it, putting viscoelastic again. I don't want this chamber to deflate. And once that is done, I am just capturing this into the capsular axis. Now it's going to be firmly there. You can see there's no vitreous disturbance. So traumatic cataracts can always be a challenge, and it's very important that you proceed very slowly and carefully, and try not to make it a more complicated issue. You can see a very well-placed 3-piece lens with an optic capture in the capsular axis. Now, hypermatures with adherent glaucomas are another challenge. You can see here there's an adherent glaucoma and there's a hypermature cataract. And because of the scar, there is a problem. So the best thing to do is obviously do a safe phacoemulsification, but at the same time, you would also want to take care of the astigmatism, which has been induced because of this scar. So you do the markings. These have been manually done, and then you go ahead. And you also know that in this area, you might have a difficulty with the rexis. You plan for this. I'm making an incision, the main port incision. And there's also another thing that once you have a pupil like this, you would also not be able to stain the capsule very well and uniformly. So once I put the air bubble, then I stain. And you will also notice another thing which I do is that in the area where I'm pushing this strap and glue into the area where it can go behind the iris. Once that is done, you go ahead and you inflate and you try to remove these posterior synecdoche. A posterior synectomy, I'm using a Sinski hook, but you can see very firmly adherent. You don't want to, many a times only detaching these posterior synecdoche give you an adequate size of pupil. But if you're not able to do it safely, you have to rethink your strategy. I'm seeing that these are very, very adherent and thick posterior synecdoche. And you should not cause too much of a pull on the anterior capsule also, because these are very dense posterior synecdoche, but I'm able to remove them gently with patience. These are not cases in which you would want to rush through things. It has to be very, very carefully done. Now I seem to have a reasonably good size of the exposure, and then I start with the rexis. And I know that I might have a slightly eccentric rexis here. It might not be a good size. Go in again. I told you multiple viscoelastic injections are important. If you think you've done once and you let the chamber collapse a little bit, obviously the rexis is not going to proceed well. But here we're seeing that the capsular rexis with the microforceps is proceeding well. But I was sure that I'm going to get a little trouble here, because here there's an adrenal leucoma and there's a adhesion here also, and I am able to pass that, but I know that it's not good enough. So I make a small cut on this side, and then again try to grasp this capsule and reshape it from the other side. And again, this area, you have to be very careful. You see, there's some amount of fibrosis of that capsule, but a reasonable size capsular rexis is done. But and most of the times, most surgeons who have a reasonable degree of expertise in phacoemulsification might think that this is a reasonably good pupil for phacoemulsification. But there can be many challenges here. So I'm going in with the phaco probe, and I'm deciding that I'm good enough to do phaco through this. But you can see this iris is coming down, this pupil is coming down, and because of this removed posterior synecdoche, there's also some amount of floppiness in the iris. So as soon as I'm holding this, some amount of iris is also coming in because of the floppiness. So I know this might not be a very safe thing to do. So I go in and put iris hooks, and once I put iris hooks, now I have adequate exposure, and then suddenly I become much more comfortable, and then the phacoemulsification is much easier. And once that is done, we know that this could be a much safer thing. Another important thing was the pupillary size also has to be good enough, because we have decided to use a toric lens in this. So we should be able to visualize the markings on the toric lens. So once that is cleared and I have a reasonably good cortical cleanup, then I go in and I implant the lens. And the use of toric lenses in such cases is very critical. This patient most probably had around 6 diopters of astigmatism because of this adherent glaucoma. And unless you take care of the astigmatism in these patients, yeah, from a mature cataract or whatever vision they get, they might be very happy, but you could make them happier. And that is why the use of torics is so important. I always felt that traumatic cataracts are a great challenge, and with some amount of thinking and planning, you're always going to find your way. This is a hypermature cataract with inadequate pupil and zero exfoliation. Inadequate for a routine case, this might not be inadequate. This is around 5.5, but you see how dense the zero exfoliation is. And the lens is so intumescent, you can see that there's going to be very high intralenticular pressure. So you go in and you stain the capsule. Once you stain the capsule, you make it central nick, and you see that there's no milky fluid coming out. So the intumescence, the raised intraocular pressure, intralenticular pressure has not been reduced in any way. But you proceed slowly, and you make a small start, and then try to make this rhexis, because it's proceeding nicely, and making it parallel to this pupil. And we know that capsular contraction is a reality, and especially in pseudoexfoliation, if your rhexis size is too small, then there's an issue of capsular contraction because of these weak zonules later on. Surely you're going to have some amount of capsular contraction. So I'm just cleaning up this white cortex and then doing a capsular nucleotomy. And what I want to show you and what I want to impress here is that obviously you're also talking about slightly weaker zonules here. So the chop is a very good technique here. It puts minimum stress on the zonules, and you're working here in the center because the pupil is small, slightly small. But when we talk about raised intralenticular pressure, not only is the anterior capsule stretched and the possibilities of complications because of the stretched anterior capsule, it can be the posterior capsule also. Because once you have reduced this, suddenly it's floppy, and on the other side there are weak zonules. You can see I'm doing the last piece, and as soon as I do that, I commit a blunder. Yeah, I should have seen there that there was a PC rent at the last piece, because the posterior capsule, which was stretched earlier, was loose, and the zonules were loose. I should have been more careful with the last piece. So what I did, I put some viscoelastic, and you could see I also put some viscoelastic between the iris and the anterior capsule. You know that the anterior capsular margin, the rhexis, is very good, and there's no vitreous in the anterior chamber. So you go in, put a 3-piece lens, and that 3-piece lens has gone in. I'm placing it in the sulcus, but very carefully I'm placing it on top of the capsulorhexis, so that smaller size of the capsulorhexis actually became a good support for this 3-piece lens. Once you see that, you check and see whether you are reasonably okay. There is surely going to be some amount of cortical matter there, which we might not have removed, but viscoelastic surely you will have to remove. And luckily we did not cause much disturbance, and this lens should stay in place, and this lens should do well. Then there's another challenge, this hypermature cataracts, which are post-uveitic. Now, post-uveitic means that not only is the capsule tense because of the hypermaturity, there's also a possibility of there are also posterior synecdoche. See how the posterior synecdoche are. There's a posterior synecdoche, and many a times there is a membrane all around the pupillary frill, the pupillary border, and then there is also the possibility of, when you stretch these pupils, when you cause some amount of manipulation, there's obviously going to be more uveitis post-operatively. So these patients are always done under steroid. I put an air bubble after I put Trepan Blue, and I'm trying to remove these synecdoche. You see the synecdoche are all around. So I'm trying to remove these synecdoche safely, and more or less I've separated them under the air bubble. I've not put viscoelastic yet. And you can see now I'm going behind and putting some more Trepan Blue. The idea is that when this pupil becomes a more adequate size, then I'll be able to have a stained capsule. Otherwise, the central part might be stained and the rest of it might not be stained. You can see now I've still a small pupil, but I have put some viscoelastic behind, and I can see that there is a membrane here. So I'm trying with the microforceps to tease this membrane away. And unless you tease this membrane away, you're never going to be able to achieve some amount of dilatation of the pupil. Because the idea is that if I'm able to dilate this pupil to an adequate size without using pupil expanders that would be better. So I removed this membrane. You could see some amount of hyphema also there. So, but still, in spite of all that, I don't see this pupil becoming good enough. So I go in and I know that I don't have a choice now. I go in and think that I could shape a rhexis here. So I go in and make a rhexis. I am seeing that there's trouble with the anterior capsule. The anterior capsule is very, very thick on this side. The anterior capsule is fibrosed on this side. So I make a small nick and I cut this capsule on this side. I try to make a shape of a rhexis with this Vana scissors. Because if I'm going to pull this, excuse me. If I'm going to pull this fibrotic capsule, which comes with hypermaturity, especially if there's uveitis or trauma, I'm going to pull all the zonules away. So you can see I've made a reasonably good shape with the Vana scissors, with the micro scissors, and now I'm trying to see where the reasonably normal capsule is starting. And once that is done, you can then go in with micro forceps and then pull it from there without the danger of the zonules being hurt. You can see I'm pulling, and that there are certain areas where the capsular nature is not the same as the others, and I have been able to shape a reasonably good rhexis and pull it out and make it slightly bigger size. And that's the biggest challenge with patients who have uveitis. You can see I'm trying to make it as big as possible. That is good enough. Now I can go inside and do a reasonably good. This is another long-standing hypermature. A long-standing hypermature means that there will be fibrotic changes and there might be other changes. You can see this cataract. This area has fibrosis of the capsule. So I'm initiating capsular rhexis with a MVR and then moving the capsular rhexis. So I'm where I'm most comfortable. So I started here, but I went into the area where I'm more comfortable using forceps. And you can see that I have created more or less completed this rhexis. Now is the difficult part, and it's very close to me, so I don't have to go far away. So the area where we had started the rhexis also comes in a certain amount of planning. You always have to be ready for this. You always have to be thinking pre-operatively as well as intraoperatively so that you are able to give it a good shape. And that is all done, and I'm very happy with what I have achieved here. And I'm at the last piece. You can see I have removed this chalky hypermature cataract, but at the end of it all, I see that my job might be not done yet. There's a plaque there, and this plaque needs to be removed. Now we don't know long-standing hypermatures, what caused them. The patient might not give you a history. We don't know what has happened here. So this is almost adherent to so you remove the cortex all around and don't go to the center. Don't go to the center. Don't try to pull it off and do whatever you can tease, you tease away. And then you look at it and see whether you will have to remove this, this plaque, because this plaque is absolutely in the visual axis. It's not going to help if you're going to do a YAG laser. That will be too much. So you just remove some area, create a cleavage, put a viscoelastic again, and see. Many a times these plaques can gently be separated away from the posterior capsule, and you can have a reasonably clear central visual axis. But sometimes there can be a little problem if you have not picked up at the right plane, if you have not touched at the right plane, because posterior capsule can be very unforgiving, and you have to be gentle and slow here. You can see at the end of the day, if I had not been able to remove this plaque, this patient would have never got a reasonably good vision. And then there's this fantastic tool that looks like the ultimate answer to the hypermature is the femto-assisted cataract surgery. Here you can see a mature cataract, and this mature cataract, with all the difficulties, with all the skills you might have, surely it's a fascinating thing to be skilled, but when technology steps in and technology makes it easier, you are always in awe that most difficult situations can be avoided. You can see here that we have a slightly shallow anterior chamber, and then there is this intumescent cataract. And as soon a white cataract, as soon as you go in, how beautifully this rhexis is done. Beautifully, you made the LRIs, you made the main ports with the femto, stain the capsule, and see how the capsule has beautifully come out, and you are able to have absolutely fine, accurate size capsulorhexis, and the nucleus is already in pieces. All you have to do is remove them. And no matter how much we decode intumescence and hypermaturity, there will always be some cases where you don't know what to do as soon as you start. With all the planning, with all the small rhexis, you have planned, the high density viscoelastic you have used, you know that things might not progress well. And as you're looking at it, you were thinking of putting more viscoelastic, this runs away, and you see you have an Argentinian flag sign. But like I showed you earlier, all is not lost. With some amount of brainstorming, some amount of skill and a cool mind, you don't have to panic here. You go in again, reshape some semblance of a rhexis. And again, I told you last time, earlier also, that these cataracts usually are soft. And the only thing you have to do is, once you remove this nucleus, you don't do, if you have to divide, if you have to chop, you don't do too much lateral separation, and you're constantly looking at the fluttering capsule. This capsule has to be fluttering, and you never come out, you never let the anterior chamber deflate. If you let the anterior chamber deflate, then there is a problem of this tear extending. And once you do that, you all the time when you come out, you inflate the anterior chamber, don't let it go away. And most probably, if you are careful, not avoiding any fluctuations in the anterior chamber, you will be able to do a reasonably good cleanup. And here I'm trying to do as much as cortical cleanup as possible. Before I'm coming out, I'm putting viscoelastic, and once that is done, you put in an IOL. Apart the IOLs which put in these situations, it's good to put in a slowly unfolding IOL. Now, if you put an IOL which opens up abruptly, you don't have control. You can see this IOL is unfolding slowly, and we have it under the capsule so that it stays in the bag. Remove the viscoelastic. And at the end of it all, I would want to tell you that challenges in cataract surgery are to be met. And with some amount of knowledge, brainstorming, looking at seniors, how they manage things, and looking at videos, listening to talks, there's a lot of exposure nowadays of online teaching. But the best teaching would always be with a guru, with always a teacher, a mentor. And I always felt that that teaching, that watching, you might not be operating, but you might be watching, and that watching might be good enough to get you through all these circumstances. But thank you all for being here, and thank you very much for this opportunity.
Thank you very much, Dr. Fazili, for a very comprehensive and excellent lecture. I'd like Dr. Maurya to give his comments, and please take the discussion forward.
Yeah. Sir, excellent. You covered it very well. The entire paraphernalia, the Pandora of a spectrum, and along with the possible complications, you managed it very well. So regarding these hypermature hard cataracts, so there are problems of the wound burn as well as the endothelia burn, and that is leading to PBK. So how you manage, especially when the ECD is very shallow?
Yeah, I'll repeat what I said. When the chamber is shallow, now by force, your direction of entry has to be such that you don't hurt the iris, you don't hurt the anterior capsule. So these tunnels tend to become a little longer. So there come the problems which you were talking about. Through a longer tunnel, if you have behind a white exterior, dark black interior, then there is the problem of having to use more phaco power. And in longer tunnels, that will cause more problem. So best is to make a shorter tunnel, and go in. That's a better thing to do. And another thing is that in a Morgagnian cataract, where there's milky fluid and the nucleus is hard, conventional things like making a trench and dividing might entail more use of phaco power. So because these nuclei are smaller in size, you can go ahead, and a peripheral chop is an excellent technique to reduce the amount of phaco power you've used. Because every time you go in with a trenching, a sculpting, and trying to divide the lens, this lens is mobile inside the bag. It's not going to stay at one place. So trenching and sculpting is out. So you'll have to use chop. And if you can use a direct chop, fine. If you cannot use a direct chop, a peripheral chop is a very good maneuver, a very good technique to be used in these cases. But most of the cases will not have a hard cataract. They might be absolutely soft. That is also a difficulty, because I told you that the posterior capsule might become lax once the interior intralenticular pressure has come down. So you have to be very careful that you don't actually aspirate too hard and have a posterior capsular end. The case in which there was pseudo exfoliation, you could see we had done so well, but in the end, at the last piece, I forgot to be a little slower and perhaps bring down my parameters to maybe an epinuclear setting and then proceed slowly.
Dr. Varun, do you prefer soft shell technique, means the use of the different type of visco to protect the endothelia as well as to keep the wound burn down?
Yes, of course, Arvind. So I have been doing that regularly, wherein I obviously I use both the normal visco as well as the viscoat, so for us to coat the endothelium properly, and obviously helps us to keep the cornea more clearer. So I generally use it, yes.
And
I have a small question for Dr. Fazli. I mean, what would be your indication for a small incision cataract surgery in hypermature cataracts, wherein you would just not want to do a phacoemulsification?
Well, I'm 100% phaco surgeon. So I personally have always felt that people would sometimes opt for SICS. So I still love SICS. It's a fantastic surgery. But to my mind, there would be very few indications for not thinking of phacoemulsification. What would be the what exactly would you have in mind to say that no, we should not be doing phacoemulsification in this case? I think obviously the level of skill can vary from person to person, and it's very important for the surgeon. I think it's critical for a surgeon, and it's ethical for a surgeon to know what he's capable of. If he is trying and attempting something which he is not capable of and he's not comfortable with, he should not try that. But we know with different levels of skill, people reach a stage where they might be 100% phaco, or they might choose some other way of handling hypermature cataracts. But obviously, the main difficulties in hypermature cataracts are the dense anterior capsule, the intumescence, and whenever there is a possibility of additional problems like a PC retina traumatic cataract or a very hard core inside a nucleus, which is very hard and very difficult to remove because it might be swimming inside the bag. So, what in your experience would be an indication for not doing phaco?
It's for the sake of postgraduate, sir. Because,
Oh,
yeah. So at what stage they need to convert into manual SICS?
so the stage at which they would convert, it's my personal feeling that when we start off with slightly poorer equipment, and we start off with the ideas which are actually poor. I have met many friends from the West who, when they saw me do SICS, they thought that it was the most fascinating skill they have ever seen, because they started learning phaco to start with. They started doing capsular access to start with. Can opener did not even enter their brains. So when they saw SICS being done, they were actually fascinated by it. So no surgery, we can say, is all of them have to be in your armamentarium. But for a beginner or a youngster who is starting off capsular access, if your capsular access has run away, better convert slowly into a can opener or reshape it. And then if you are not confident enough to go inside that bag and remove that nucleus well, it's always better to be safer. It's always better to be on the safer side. My only issues with the SICS in such circumstances is that you should not allow the anterior chamber to collapse. If you allow, so visco expression is a fantastic tool there. Visco expression of the nucleus, so whatever cortex there is, you might want to remove it. You wouldn't want anterior chamber fluctuation, because once there's a tear and then there's a fluctuation, it's going to move across the equator and go to the posterior capsule, or whatever surgery you're doing. So those people who are converting because of a difficulty in the hypermature or the intumescent cataract, they have to know that visco expression or using an AC maintainer and then delivering the nucleus without the chamber collapsing might be the way to go.
Rahul Vaikar, can I have your comments on the lecture and any questions you would like to ask Dr. Fazili?
First of all, I'd like to compliment Dr. Fazili for very nicely and comprehensively covering the topic with nice
You're very
visuals.
kind. You're very kind. Thank you.
Very good visuals, which leave no scope for a doubt to anybody listening to you, sir. But now, from my take on white mature cataract is, it starts from the pre-operative evaluation. So for any beginner in phaco, or for any surgeon for that matter, you have to identify when you are being on the slit lamp the bulging of the anterior capsule. If you can make that out, then you'll be better prepared. That is number one. Number two is you have to look at the core of the cataract. Right? Try to look for a brownish hue. If you get a brownish hue, then you are likely to encounter a hard cataract, hard nucleus inside. And if it is a white this thing, then it's going to be a soft cataract.
Slightly bluish. Yeah.
So, so that way you are mentally prepared what you are going to face while operating. Then a few things which very nicely already brought out is you have to maintain a deep flat anterior capsule. So use a high density viscoelastic all the time. Keep the AC well formed. AC should never become shallow while doing rexus. So for that, one thing what could be done is you load viscoelastic in your cystitome instead of fluid. So that at the time of doing rexus with the cystitome, if you feel that there's slight bulge forward of the anterior capsule, you can immediately inject viscoelastic through that only and maintain a deep AC. And side port capsular rexus is better than the main port capsular rexus because the visco doesn't leak out. So that is also very important. And for a beginner, that word of caution, as it's already been discussed. Once you get an extension of the rexis, you should not venture with the phaco because you are not confident. It's only with experience that you can do phaco with a torn anterior capsule. So you should be willing to convert at all the time for a beginner. So that is very important. And then another thing also already covered is when patient comes late, there are certain cases when after intumescence all the fluid cortical matter has leaked out. You are left with only the capsule and the lens nucleus inside. So rexis becomes very difficult, and at certain point of time you have to use scissors, as was shown in one of the videos by Dr. Fazili. So those are again difficult cases to do. So for beginner, be willing to convert. That is, they do not look at the skill of Dr. Fazili, who nicely handled and performed phaco in all such cases. For a beginner, he should do with open mind and be prepared.
Do we have any questions from the postgraduates for Dr. Fazili?
Yes, sir. First of all, there's a commentation on the live chat on YouTube for Dr. Fazili, sir, that he's very beautifully explained presentation and amazing surgical videos. And I second that, sir. This was an amazing compilation. Everything was covered so well. Let me go on to the question.
Thank you.
One of the students has asked, sir, in long-standing hypermature cataracts, sometimes the bag gets folded after delivery of the nucleus. So any precautions or extra precautions to avoid such a happening?
The folded bag perhaps means that there are weak zonules. Yeah, most probably that might be why I would take a folded bag as weaker zonules. So if the capsular axis is good enough, you have an intact capsular axis, then it would be wise to go in with the CTR, because folded axis, folded bag means that zonules have ruptured somewhere. And once zonules have ruptured somewhere, you need to put in a CTR. And if obviously hand it over to a more senior guy, because that would be the first step, and then put in a CTR. If the zonular weakness is too big, then you might have to put in a segment. But if that happens and there's nobody supervising, which should not happen, that nobody is supervising. Always surgery done by our juniors needs to be supervised, and perhaps the best microscope and the best audio visual, the cameras and the screen, even if the senior is taking a cup of tea, the senior should be watching what the juniors are doing. And once you see that the bag is folding, and then you will have to go in and leave it to a senior guy, and that senior guy might actually put in a CTR, might put what we know as a capsular capsular segment, and then this can be handled. If the bag has completely folded, now you know that zonules are lost, then it's always better to go in and remove the whole bag without disturbing the vitreous, or leave it to a senior surgeon to go in and implant either a retrofixated IOL or do a sulcus scleral fixation. Yeah, but as soon as the bag sort of crumples, and it's time to change hands to a more senior person.
Dr. Gohar Ahmed, want to say something? Sir, are you there? You have raised your hand.
Kanika, do we have any more questions for Dr. Fazili? You can continue with the questions in the meantime.
So there's one more part to it. For new surgeons, what extra precautions to take in cases of hypermature cataract in SICS?
Now, you see, I said in this presentation that you would want to aim for a smaller rexis to begin with. And because a bigger rexis is always more difficult to make. So we finally aim at an ideal size of rexis. So, but here we know that shaping a capsular rexus as such is difficult because there is raised intralenticular pressure. So, the biggest difficulty is that. So, but if you have a smaller size capsular rexus in SICS, then there's a difficulty removing the nucleus through that opening. So it's a good thing making a small capsular rexus and then giving some relaxing incisions in the capsular rexus. And then if you are don't have the skills to reshape it to a bigger size, it's good to give some gentle, controlled incisions in with scissors, so that you have an area through which the nucleus might come out. What we used to call earlier when we were doing extracapsular cataract surgery, conventional extracapsular surgery, the envelope technique. That you make a cut in the anterior. This is your lens. You make a cut in the anterior. You take out the nucleus and the cortex, and then you put in the lens inside, and then remove some area in front by making nicks in the anterior capsule. That can be a very good way of handling. But important is that some people who are postgraduates, let's say in the garment sector, and they don't have higher density viscoelastics, it's good to spend some of your own money and buy higher density viscoelastic and then use it so that the surgery becomes safer. Obviously, the control, the counter pressure of a higher density viscoelastic to control the intralenticular pressure, raised intercondylar pressure, it will give a lot of ease. I think that's the way to go.
Thank you, sir. There are no more questions on the YouTube channel, sir.
Great. So, Dr. Fazli, personally speaking, what has been your experience with the femtorexis in cases of hypermature cataract?
I don't have a femto assisted cataract surgery. The video I shared was from Dr. Mahipal. Yeah. But obviously you could tell us about it.
So basically, I have a catalyst platform here, and I've done loads of hypermature cataracts with this. So what I personally felt is that you do have some adhesions left. So though you get a very round circled rexis, but when you are pulling it, I mean, when you are removing this femtorexis, you have to be a little more careful, because compared to normal cataracts, since the cortex is liquefied, even when the laser hits the capsule, you do have some uncut areas or some adhesions left. So unlike a normal cataract where you could just go in and, with the help of a forceps, just remove the rexis, here you have to be a little more careful. You have to make sure that the adhesions are nicely separated before you remove them. Initially, in my days when I was just started off in 2016, I had a case where in a hypermature cataract, I just got hold of it and removed it, and the rexis extended, and I had a nucleus drop. So after that, I learned my lessons. Obviously, I learned it the hard way. But so I obviously feel that you have to be a little more careful, but it does give you a very nice round rexis. So unlike the other cases where you have to make a small rexis and then do a double rexis to enlarge it, you can do it in one step itself.
Yeah, and again, we come to the same thing. It's a paradox that we first learn skills, we first learn the difficult way to do things, and then we come to technology that makes everything easier. There might be areas of the rexis which you were not able to, where it was attached, but a small pull for an experienced surgeon, it should not be a big deal. Yeah, generally speaking, it's a massive tool. We did not talk about Zepto, though. But yeah, hypermaturity also brings in some zonular weakness. There is no confusion about it.
No confusion.
So I've always been a little skeptical about Zepto in these cases because you don't know, because basically the mechanism is such that in slightly weaker zonules, you might actually be causing a problem. So one has to be very careful with that option. As compared to that, obviously, the femto is a great advancement in handling cases like this.
Yes, Arvind, you want to
Yeah,
say something?
actually, so in intermittent cataract, hypermature cataract, there are three forces. Number one, the taut anterior capsule because of the raised intralenticular pressure. Number one, and the intermittence of the nucleus itself. And then there are the posterior vector forces because of the vitreous thrust is there. So how I manage these cases? So I prefer to give, if the eye is short axial length, so I prefer to give mannitol. That helps a lot. And by doing the hypertonic, using the pinky ball sometimes, so it reduces this vitreous load by manyfold. It's far much better than the using the IV mannitol. And now coming how to deal with this the raised intraocular. So I've used this RF capsulotomy. A very small capsular axis is made that is attached in the Ortley machine. It's not with the other machines. So a very short microcapsular axis is made, and then we can go inside and reduce the intralenticular pressure by removing the liquefied cortex, and then we can go ahead and enlarge the axis. And also puncture axis is also a good technique, but sometimes because it opens like a flower, so sometimes it has means propensity to extend when we are doing puncture axis. And also then a very simple technique of sieving needle microcapsulotomy, simple this pin, the hairpin we can use and bend it. And so it opens very small microcapsular axis, very minute 0.1 or 0.2 millimeter. So it comes out, the fluid comes out, and we can give multiple these within the mid periphery, not extending beyond 4.5 millimeter. So it helps a lot. So I've used, and the simple needle aspiration is also a good technique, but again, it extends. So the simple needle, instead of that, I prefer the sieving needle microcapsulotomy, puncture axis, and of course, this RF capsulotomy, a very small axis of 2 millimeter first in the center is made.
I think it's a very important comment for all the postgraduates, because
Yeah.
when they answer the Viva, all these things they
Yeah.
should be mentioning, even if they've not seen this practically being done. I think with this we come to the end of a beautiful lecture. I think hypermature cataracts form a fair subset of cataracts which we handle in our country, considering that we do have a very big load of low socioeconomic strata, which obviously wait for the cataract to become mature, and that's what the normal convention is. We should only be doing it जब मोतिया पक जाता है, and they don't realize that it's much more difficult to handle hypermature cataracts unless you travel all the way to Srinagar to get it done by Dr. Fazli.
Thank you very much. That's very kind of you.
Absolutely.
So I think Dr. Fazli has done a great job. It was a pleasure attending your lecture. I would love to travel to Srinagar to be with you one day. Kanika, thank you very much. Looking forward to your skit in Agra. Colonel Vaikar, great to connect with you and know you since you're a fellow alumnus of Shankar Netralaya. And as usual, the dynamic Carmen. Thank you very much. I wish you a great day. All the best. Thank you. Bye-bye.
Thank you.
Bye. Thank you.
Good night, everyone.
Good night, sir.
Good night.